equivalence trial. So what is a non-inferiority trial? An aim of a non-inferiority trial, I think by mistake it has been written inferiority, read it as a non-inferiority trial. So the aim of this non-inferiority, what does this word suggest to you? Non-inferior. Does it say that it will be superior, or will it say that it will be inferior? So no, if you closely look at these two words, non-inferior, it only suggests that the treatment will be nearly equal to the existing treatment, the new treatment. So we try to prove that the new intervention is at least as good as the current intervention by demonstrating that the difference in proportion or maybe mean, whatever outcome we are taking, whether it is in the form of a mean or it is in the form of a proportion, because by this time, all of you are clear now, how do we define our outcome? So are we going to measure that outcome in the form of a mean, that is a continuous variable, or you want to have a categorical variable in the form of a proportion? So in this case, if I'm demonstrating that the new treatment is as good as the existing one, but again, I define some margin, like what margin will I call it will be the clinically meaningful difference. So that setting up of margin is very important. And it's a separate session. How do we set up that margin? Maybe superiority margin or non-inferiority margin, because we cannot say that if the drug is effective, or maybe let's say that the cure rate of a new drug, which is the A, is 65%, whereas the existing drug B, it has got a cure rate of 70%. So although this has got a cure rate of 5% less, but we will not call it as an inferior. Why? Because we have set the inferiority margin maybe 7%. So if the new drug, the effect falls in that 7%, then we call it as a non-inferior. But why do we actually do it? So non-inferiority trial, basically we do it whenever there is some advantage over the cost. Like for example, if the existing treatment is costing maybe a person 3,000 rupees a month, or maybe 10,000 rupees, let's say, and the new treatment, it is costing half of the amount of the previous treatment, maybe 5,000. So if the cost is very less, it is cost effective. So even if the treatment, it is the outcome, it gets lessened by, say, that margin which you have fixed, maybe the 5% or 7%, and if it lies within that margin, you can very well accept that new drug, although it is little bit less effective. But since that less effectivity in the other form of, like maybe the side effect, maybe the side effect is less, maybe the pill burden is less. The new drug you have to take only once in a day, and the existing drug has got 3 times scheduling in a day. So these are the other factors for which we do the non-inferiority trial. So that non-inferiority word is only applicable maybe for the outcome, the primary outcome, but there are secondary outcome also, like in the terms of a side effect, in terms of the cost, in terms of the dosing schedule, in terms of maybe taste. So there may be a drug which is very bitter, and maybe, like, especially for the pediatric formulation, and the new drug is very good in taste and acceptable, that can also be the secondary outcome. So for secondary outcome, generally we set this non-inferiority margin up to certain limit to the primary outcome, so that we can have those secondary outcome into play. So that's why we set a non-inferiority margin. Now we do an equivalence trial. So what is an equivalence trial? The combination of this superiority and inferiority, we call it as an equivalence. So we try to prove that neither the drug is inferior and not superior to the current drug by demonstrating that the difference in proportion in the two group is of no clinical significance. So this also we do whenever we want to have like other things into play, like less cost, or maybe more acceptable to the community, less dosing schedule, less side effect, etc. So for those things, we do such type of trial, and they are the non-inferior and the equivalence trial. Now we have discussed this concept in the last session also, and this is the concept of statistical versus clinical significance. Now, what is a statistical significance? So whenever we set a value like alpha error at 5%, and we say that the p-value is less than 5, and maybe if the confidence interval, it is significant, we call that study or that result to be a statistical significance. But there is a difference between these statistical significance and clinical significance. If you increase the sample size, even if very less clinical significant value will also be a statistical significance. So which is more important for you, statistical significance or clinical significance? All of you, please type in the chat box. I may see the response. So which is more important for a clinician, a statistical significance or a clinical significance? So Varun, Non-Inferiority, and Sashikant, Panigrahi, many people, they are writing clinical significance. So you are right, because definitely the statistical significance is there to prove your hypothesis. But ultimately, what do you want to do? You want to use this knowledge in the improvement of maybe the patient welfare, or maybe the outcome, if it is a cure rate, or maybe if it is the improvement in certain outcome like blood pressure, sugar, whatever. So that clinical significance is more important to you. If it is coming in both ways, like statistical significance and clinical, that is the best thing. So we want to ensure that statistical significance, that's why we take the adequate sample size calculation, and we do the sample size calculation, so that that clinically significant difference we can prove in our hypothesis. But ultimately, this clinical significance, how do we determine this clinical significance? So basically, there is something known as the effect size. And based on the basis of these effect size, you can say whether this significance, whatever it has come out, or whatever margin you have set, whether that is clinically significant or not. And many of you know that there are various measurement of this effect size. Like there's one way of that Cohen-D. That value of Cohen-D tells us regarding the effect size. So let's see this with one example. And consider these example, maybe for the people who have attended this before, you may find it repetition, but since we thought that we will include this concept here as well, because there might be people who are joining this webinar for the first time. So you plan to test the effectiveness of a new drug X, maybe in hypertensive patients, in comparison to the standard drug. So standard drug is the S and new drug is X. So I have designed an RCT, and I have obtain this following outcome. So the blood pressure of the patients on drug S, because my goal of the giving this drug is to attain a normotensive status. So maybe on the patients who are on drug S, the mean systolic blood pressure is 128 with a standard deviation of 8, and the blood pressure of patients on drug X is 118 with the standard deviation of 10. So in this case, what is the outcome? So outcome is the, what is the mathematical difference? In these two, the mathematical difference between the means of the two group is 10 millimeter. So the difference between the 128 and 118 will be 10 millimeters. So I have proven that this 10 millimeter, this difference is maybe clinically significant for me, because the new drug is able to lower the BP by 10 millimeter. Now let's see this. In this case, what are you seeing? That the new drug is lowering the blood pressure only by 2 millimeter. The existing one, the mean BP was 128, whereas the new drug, which is the X, that is lowering the blood pressure by 2 millimeter of mercury. So the difference between these two, if we focus on the mathematical difference between the means of the two groups, they are only 2 millimeter. So now, which outcome is better in your case, the first RCT or the second RCT? If you are a clinician, so what is important for you? A lowering of 10 millimeter or lowering of 2 millimeter? So yes, lowering of 10 millimeter. That's why the first will be the answer. Outcome 1, 2, or can't say. So outcome 1 is better for you. But again, we can't say, because it depends on the number of samples what we have used, because we don't know whether that 10 millimeter is significant or 2 millimeter is significant. So now see this. So initially you saw that there was a difference of 10 millimeter, but the sample size, it was done only on 20 individual. That randomized clinical trial, it was done only on 10 samples, and that's why you can see that it was not significant. The p-value was not significant. So ultimately you are gaining a clinical significance of 10 millimeter, but you are not gaining a statistical significance because it was done on a very small number of patients. So in this case, along with clinical significance, what is your desire? That you should get the statistical significance also. Otherwise, nobody is going to follow your recommendation, whatever you have given. Whereas the second study, it was done on 100 patients, 100, rather 200. So 200 individuals, they were randomized into 100 and 100 in each of these arms. And you can see it is statistically significant. So in this case, in the second case, what you are seeing? That this clinical, it is not significant for you, but it is a statistically significant. Whereas in the first case, it is clinically significant for you, but statistically it is not significant. So mathematically large difference can be statistically non-significant if the sample size is small, or a mathematically very small difference. Like in this case, you can see the 2 millimeter difference of mercury can be statistically significant if the sample size is big. And you can see there was a difference of 10 times sample size. In the first scenario, we took only 20 patients, 10 in each arm. In the second case, we took 200 patients, 100 in each arm. So we have increased the sample size by 10 times. So now consider again the following two scenarios. So like I plan to test the effectiveness of a new drug, that is the X1 and X2 in hypertensive patients in comparison to the standard drug S. So now you can see that standard drug I have, the other two drugs are like maybe the 100, and the sample size is same. So in both the arm, you can see it is the 100, and in the X2 also it is the 200. So in this case, you will see that there is a mean difference of 2 millimeter and it was statistically significant. Whereas in the second case, you will see that the mean difference is 10 millimeter and it is also statistically significant. So in this case, if you have seen this, now answer that which outcome is better. So yes, Varun, Tejasvi, like many people are writing, Shashikanta, Dhriti, Chunki. So yes, second outcome is better. Why it is better? Because in this case, you are having a clinical significance also, and you are having a statistical significance also. So in this case, an average reduction of 2 millimeter of mercury in systolic blood pressure is clinically not that significant as compared to the 10 millimeter of mercury. So a statistically significant difference will be clinically non-significant if value is below a desired margin. Similarly, a statistically significant difference will be clinically significant also if the value is above the desired margin. So this desired margin in the randomized controlled trial, it is known as the clinical meaningful margin or the least relevant margin. And there is a way to set this margin also. You cannot decide arbitrarily regarding these margin. There is a scientific way to decide this, which we are not covering in this session, how to decide for the clinical meaningful margin. Usually we do it by the literature search, and then we decide there are other methods also, but we are not covering that in this session. Ultimately, it is the clinician who decides this meaningful margin. Maybe like prior to clinical trial, you can do a lot of survey, you can do a lot of consultation with the experts. There are Delphi methods, you can have several meetings in your department to decide prior to the clinical trial. An expert committee meeting also you can keep with this clinical meaning, with the decision how to decide for this clinical meaningful difference. So it depends on the objective of study also. Like if there is a study where the mortality, you are doing a study on mortality rate. So even a small reduction in the rate of mortality will have a significant effect on the lives of those people who are at risk of mortality. But if you are doing something on like improvement in sedentary lifestyle, modification, maybe a dietary modification, So a small reduction is not going to have a significant, so maybe you are aiming at a larger reduction. So that depends on the objective of the study and the aim of the study also. So for the sample size estimation, we have two types of input for the sample size estimation. So in one case, you can compare the proportion. So first, any sample size, you first have to decide about the outcome. How you are going to measure the outcome? Are you going to measure it in the form of a mean, that is in the continuous scale, or you are going to measure it in the form of proportion? Because these are the only two way of measurement. You can have median also, but we are not going to discuss about the median, how to determine sample size using median, but you can do that also. So now you can compare the two proportion, because it is a randomized control trial. So I hope that all of you know that there will be two arms. So there will be a control arm we discussed, and there will be a treatment arm. So there will be difference in the proportion. This odds ratio generally we don't have in this concept of this randomized control trial, but again we do calculate sometimes, and sometimes you can have the relative risk also. Alpha level, yes, you determine the alpha level, that is the level of significance. We usually keep it at 5%, but in many studies today also you will see in the example that many people reduce this alpha level. You know that if you reduce the alpha level, the sample size will increase. So larger the proportion difference, the first one, the lesser will be the sample size. The larger the odds ratio or the relative risk, lesser will be the sample size. Smaller the alpha level, more will be the sample size. If you increase the power of the study, what is power? Is basically the 100 minus beta error. So if you increase the power of the study, the sample size increases, and then you do the adjustment. So with this adjustment also, there's an increase in sample size, because you do the adjustment for the non-response, you do the adjustment for the other type of, like maybe the ratio in the control arm as well as the treatment arm. So is it 2:1 or 2:1? So you do such adjustments also. And if it is a cluster randomized trial, then again you do the adjustment for the clustering effect also. If you are measuring your outcome as a continuous scale, then also you measure the mean difference of those two variables. You measure the standard deviation, and then you have, you don't measure it, actually you have these values from the previous study. You have an alpha level, you have a power, and you do the adjustment. So there are different type of trials. We have seen this slide initially also. So I will not discuss this superiority now. So this inferiority, if you say this line is of no difference. So here you can say that if you are taking maybe a relative risk, it will be like 1 when there is a no difference. And if it is a proportion, then obviously there will be no difference. So this is the new drug, and this is the the existing drug. So in this case, you can say we set a margin. So this margin from the no difference to the clinically least difference, this we call it as a non-inferiority margin. Similarly, if you see the equivalence, you set a margin both below and above this margin of a no difference margin, and then you call it as a equivalence. So now there are following steps in the sample size calculation. First, you identify a research question, and the research question and the study variables could be in the form of a mean or in the form of a proportion that we have discussed. And before we identify this, we do this with a thorough literature search. So for clinical significant difference or this margin also, you set this margin with the literature review. So you do the literature review, and then you search for the margin, and then you take a margin maybe after the expert consultation or the meeting with experts and the committee. Then you set the parameters for the sample size calculation. So on the basis of your consultation and your research review or the literature review, you set the parameters for the sample size calculation. You calculate the sample size, then you do the adjustment if it is needed, and then you do the write-up. So now following aspects are needed to consider for a sample size calculation. So this we have discussed the least relevant difference or the clinical significance. So by how much should the new intervention be non-inferior than the reference intervention or the existing intervention? So this we have discussed that we do the thorough literature search and we take the previous literature and then we do the consultation also. So by these two, we decide for a non-inferiority margin. Then we set the type 1 error rate, which is the alpha error. Usually we keep this error at 5%, but in many studies, you will see that the authors or the researcher, they keep it at 2.5% also. And then the third is your type 2 error rate. You generally fix it at 20%. That's why generally PAR is set at 80%, but you can have the PAR maybe at 95%, 90%, 99%, depending upon your need. So what are the inputs which we need if we do a sample size calculation? So we need the proportion or mean of outcome in the standard treatment group. We need the expected proportion or mean of outcome in the new intervention group. Then we set up clinically acceptable, minimum clinical acceptable difference for the non-inferiority and equivalence type of trial. Then we set the level of significance. Then we set the PAR, and then we set the alternative hypothesis. So generally in case of a non-inferiority and superiority, this alternate hypothesis will be always one-sided because you are considering that it will be non-inferior, and in superiority also you are considering that it will be superior. In case of an equivalence trial, you set these two as a two-sided hypothesis. So now let's do the calculation. So first we learn about the how to calculate the sample size for non-inferiority type of trial for a continuous outcome. So we discussed this in the last session also regarding the common approach. So if you see the statulator, we'll see the interface. You will see that there is a term known as the equality and there is a term known as the equivalence. So these are two separate terms. Equality is only when you are comparing the two type of proportion, but you don't set a margin. And that is usually done in case of a cohort study, or maybe in the case of a case control, where you are seeing the outcome as a risk of exposure or risk factor in the disease group and in the non-disease group. So if you see the common approach, then there many people, they use this sample size. So this U plus V square, we'll discuss what are these U and V. Sigma 1 square plus sigma 0 square, and in the denominator it is the mu1 minus mu0 whole square. This mu1 minus mu0 is the difference in the mean outcome for the both groups. If you see this U, it is the desired PAR, which is like 0.84. This value of U is 0.84 for 80% of PAR. Then we have this V. It represents the desired level of statistical significance, and its value is 1.96 for 5% of alpha. So this U plus V square, it will be a fixed number if you are fixing the alpha and beta. That means at 80% of PAR and 5% of alpha error. This sigma 1 square plus sigma 0 square, that is the standard deviation in the exposed and standard deviation in non-exposed. So this is the formula if we use the equality option, but that option should not be used if we are using a clinical trial sample size calculation, because there we set a clinical significance margin which is absent from this formula. So the recommended approach is, this is the sample size. So how do you do it? You multiply this by 2. That means in each arm, this U plus V square is same, which you have seen here. If you see this U plus V square is same. What you do, you just square this. And then in the denominator, it is the D minus this delta. Now, what is this delta? This is the minimal clinical accepted difference. So basically, this delta is the non-inferiority margin or the equivalence. In case of an equivalence trial, it is the equivalence margin. So this is in the case of a mean. So if you closely see these two formula, in this case, you will see that if you like, if both these two are same, I mean, in this case also, this is the sample size in each arm, whereas in this case, you will see that we have squared this, and in denominator, we have something known as this delta, which is the clinical accepted mean difference. So we will see, the application of this formula when we will calculate the sample size. So this represents the desired power, which is 0.84. This V represents the alpha level, which is 1.96. This is the pool standard deviation of the outcome. And this we have discussed regarding the delta, that is the minimal clinically accepted mean difference. And this D is the expected mean difference due to the intervention. So now coming to the hands-on. So this is one of the original article. So the title of this study is paclitaxel eluting or sirolimus eluting stents to prevent restenosis in diabetic patients. So by the title, if you imagine the methodology, what they must have done. So yes, I will explain this pool standard deviation because there is a definition of pool standard deviation. And this pool standard deviation, if you see here, that's sigma 1 and sigma 2. So basically it's the sigma 1 square plus sigma 2 square under root. That's how we calculate. But if you see, if you think there is a very little difference between these two standard deviation, you can take average of these two. So there is a formula for pool standard deviation, and you can refer our session on the case control study where we have discussed this concept of pool standard deviation in detail. So U in this first formula, it is the, actually we have removed this U and V because if you see this, basically this U is by mistake, it is this arrow is at 2. We have taken this from a Kirkwood. There is a book on sample size calculation and statistics by Kirkwood, Betty Kirkwood. So what he did, like usually you will see in traditional formula, you will see this alpha beta by 2, 1 minus alpha by 2, beta by 2, just to simplify those notations. Because if you use those notations in the sample size formula, it used to look very heavy. So what he did, that he simplified these two alpha and beta, and maybe beta by 2 and alpha by 2 by these U and V values. And he has fixed this U and V value. So basically this U is for the power. So U is power, which is at 80%, the value of this U is 0.84. And this V is basically the alpha error, desired level of statistical significance, like whether you are keeping it at minimum, we keep at 5%. You can have like 2.5 less than that also, but we set at 5%. So the value of V at level of 5% is 1.96. So this 0.84 and 1.96, these are the two values, that is U plus V. If you are not increasing the power or not decreasing the alpha, if you plan to increase the power, if you want to have a power of 90%, then the value of U, it changed to 1.28. You can refer to that statistical table where these value of, it keeps on changing. So this U and V, I hope now you know what is this U and V. So basically this U and V is for the alpha error and for the power of the study. U is for the power and V is for the alpha error or the clinical significance. So is it clear? I think one of you can type yes. Okay. Now I assume that you know what is this U and V. So coming to this example of paclitaxel eluting or sirolimus eluting stents to prevent restenosis in diabetic patients. In this, what is the outcome if you see this? What is the outcome in this case? All of you, please write. Outcome of the study. In this case, by seeing this title, what is the outcome? Restenosis. Yes. So basically, it's the prevention of restenosis is the outcome. And the two treatment arm are the paclitaxel eluting and the sirolimus eluting. So sirolimus eluting was the standard stent, and this author wanted to test the paclitaxel eluting, whether it has, and this is a type of non-inferiority trial. So I'll just read out this. So drug-eluting stents markedly reduce the incidence of restenosis. I have just taken the excerpts from the journal, and they reduce the incidence of restenosis as compared with the bare metal stents, both in patients without diabetes and in those with diabetes. However, no data are available on the relative efficacy of a particular drug-eluting stents in patients with diabetes. This issue has important implications for the selection of the most effective therapy in the high-risk group of patients. So therefore, we designed a prospective randomized trial to compare paclitaxel and sirolimus eluting stents in patients with diabetes and coronary artery disease. So the objective of this study was to assess whether the outcome of treatment, an outcome was a restenosis. So the outcome of the treatment with the paclitaxel eluting stent was not inferior to the outcome of the treatment with the sirolimus eluting. Now, in this, we are not going to tell you the detail why the author planned. Maybe with the sirolimus, maybe there were some side effects or some cost issue must have been there. That's why he's saying that if it is non-inferior to sirolimus, then we can go for the paclitaxel also. So the author has set the non-inferiority margin as 0.16 millimeter. So you can see here the calculation of the sample size was based on the margin of a non-inferiority for in-segment late luminal loss of 0.16 millimeter. This value is equal to the 35% of the assumed mean and standard deviation late luminal loss of 0.46 plus 0.45 millimeter. So what is this 0.46? So basically this 0.46 luminal loss will be there with the paclitaxel also, but this sirolimus also. And this person has assumed that maybe if this paclitaxel will also have the same 0.46, but even if it causes a luminal loss of 0.16 more than this, then also it will be acceptable. So as they have set this margin, and they found an analysis of a series of diabetic patients treated with the sirolimus stent at a participating center 10 months that preceded the initiation of the study. So maybe on the basis of a pilot project or some observation, they have set this margin. So the up till, if you add these two, 0.46 plus 0.16, so the total will be 0.62. So they are ready to accept the luminal loss till 0.62, because 0.46 is there with the what was a new drug, sirolimus also. 0.46 is the luminal loss with the sirolimus also, but with paclitaxel they are ready to accept even the luminal loss of 0.62. So are you people getting these concepts? What is the concept of non-inferiority? So they have set a margin. Yes, there is a luminal loss which is more than the sirolimus, but if it is superior in the other aspects, like maybe the cost or maybe the side effect, ease of stent, putting the stent, those things I am not putting here, but those are the reasons why we go for a non-inferiority trial. So in this case, the author is ready to have a luminal loss of maybe 0.62 because he has fixed the margin, and now he's testing. So how much sample size will he need? So luminal loss should not be more than this amount with paclitaxel with respect to the sirolimus, and this 0.46 is the luminal loss with the use of sirolimus. So yes, maybe you need more time to understand the concept. Yes, I do agree with you, because it takes a little, when you do it and when you read it many times, that's why I have tried not to put the concept of those confidence interval, and there are a lot of concepts involved here, but that will make the session a little heavy. So it is just the, maybe you can say this is introduction. And then we will have a workshop. We are planning to have a workshop on all these series of sample size calculation, where we may use the G power also. And then each of you will do it, and then you can learn better, because it's just the sensitization of all of you, because in 1.5 hours, it is not possible to make you understand each and every concept. So in this case, the author has used the one-sided level of alpha, which is 0.05, and he estimated that at the 80%. If you see, it is at the level of 80%. So now let's see what are the what are the inputs which I need to put. So if you see, it is the luminal loss 0.46, but again, if you see the value, this will be the same. So let me open it. So now, do you understand why these two values are same? And then their clinically acceptable non-inferiority margin is 0.16, and standard deviation for this luminal loss was 0.45. The level of significance was 5%, and the power of study is 80%. And we know that in non-inferiority and superiority, in both the cases, the alternative hypothesis will always be one-sided. So let's open the statulator. So in this case, if you open this statulator, you can see I have to first use a compare the two independent means. So I have clicked that because it's the mean. And in this case, you can see here, there are 4 options. There's a equality, there is a non-inferiority, there is a superiority, and there is a equivalence. Yes, I'm explaining why this is 0.46. So this is a non-inferior. So I will click this non-inferiority trial. So if you click this non-inferiority, you will see that there are 2 options, expected means and expected difference between the mean. So I have clicked this. So you will see why I have fixed this as 0.46. So if the author has not explained anything, in this case, you will see that 0.46, if you go back, in this case, 0.46 was the luminal loss with the sirolimus. So this author has accepted that the newer treatment will have not more than 1.16 of the existing one. So the null hypothesis will be like the both treatment are same. And the alternative hypothesis will be like there will be a difference of 0.16 between the two. Because why I have said 0.46? Because I'm saying that what is non-inferiority? Non-inferiority means it will be at least as good as the existing one. So generally you will see, ideally there should be a level of this improvement. But what I have seen in general calculation of all the article, that they keep this difference to 0. That means they say that even if it is as good, because if you increase this, then it will go to the superiority trial. If I say that this will be better to the newer drug will be better than this, then only I can say now that this 0.46, the luminal loss, if it is less than that. So in superiority trial, I can say that the luminal loss will be less. But if I'm doing a non-inferiority trial, so what I'll say, that this will have at least this much with the existing one. So if the 0.46 is the existing, I am also saying that 0.46 will be with the newer one. And apart from that, even if it is less than that, like even if it is up till 0.62, then also, because that non-inferior, I will not call that non-inferior. I will not call that non-inferior. So that it can be like 0.46, 0.47, 0.48, 0.46 till 0.62. All that range will be the non-inferior one. Did you get it? You will see the other example, then it will be clear to you. And we'll see in the formula also. I just see this example, then I'll go back to the formula, and then I'll explain what is the difference if you take this margin maybe not equal. So in this case, you will see that this was the input. So I'll go back again to the statulator. So the difference between the mean will be 0 here. So if you see difference between the two mean, it will be 0. What was the standard deviation? So if let me go back, standard deviation was 0.45 and 5% and 80%. So I'll go back to statulator and 0.45. So I will have this as 0.45. And non-inferiority margin, what was the non-inferiority margin? It was 0.16. So I'll keep it as 0.16. Now, can you say here in non-inferiority margin, there is a minus sign. So this minus and plus, it does not matter here. Why? Because let me first calculate it. So it is 98. So if the outcome is positive, in this case, the outcome is a positive outcome. That means there is a luminal loss is less. This much luminal loss, you are preventing this much of luminal loss. So this is a positive outcome. So if the outcome is positive, you set this margin as negative. And if outcome is negative, you set this margin as positive. And then you calculate it. So this is 98. Actually, so in this case, if you go and see the sample size 98, so what the author? So author has estimated a 99 patients per group. So it was almost the same number which we tested. So now let's see. In this case, if I go back to the formula here. So can you see a mean as an outcome? You can see here this D. So D is the expected mean difference due to intervention. So this D we have taken as 0 here. The mean difference between the two groups, 0.46 both. And this delta, this we have taken it as a 0.16. So if you have any value here, and if you deduct it, then this whole number will be, and if you square it, so it will be less. So the sample size will be more. So if you have some difference between these expected mean difference due to intervention, your sample size will increase by a very huge amount. Like maybe it will go into thousands, 2,000, 3,000. I'll just show you with one example with this only. Suppose if the author said that there was a difference here you can see that the expected difference is less. Maybe if you see that there is some expected difference, maybe if you say that 0.12 was the expected difference, and then if you calculate, so in that case, so this minus is not going to affect. Maybe if you remove, and if you have this 0.12, so you can see the sample size, it is increasing to 1565. So by this, if you have some value here, if you keep this to 0.04 and then calculate, then the lesser the difference, the lesser the sample size. So that's why generally people, what they do, they keep it at 0 and then they calculate the sample size. Because if you calculate the sample size taking the mean difference as 0, because it's a non-inferiority trial. So you say that it will be as good as the existing one. That's why the mean change you take as 0, and then you set a non-inferiority margin that even if it will go up till 0.62, because most of the time we don't have the value for the other, like the change in the, with the other, the existing one we don't have. That what was the luminal difference or the existing change. So that's why you take the difference of these two values as 0 and you set a non-inferiority margin and then you calculate the sample size. Coming to the other example. So coming to this example of, there's another example, like day patient treatment after short inpatient care versus continued inpatient treatment in adolescent with anorexia nervosa, a multi-center randomized open label non-inferiority trial. So what is the outcome in this case? If you read this, what are the two treatment? Like if I say, what was the intervention? So it was the, so outcome was the anorexia. Yes. And anorexia mein what will be the, basically what is the aim of the treatment for anorexia? It's basically the weight gain. So they are seeing that whether the prolonged inpatient admission is effective, or even if you discharge the patient and do a daycare treatment, will that be effective? So the restoration of a healthy body weight is one of the key aim in the treatment of anorexia nervosa. The weight gain during the admission and during the intensive phase and the maintenance phase of weight gain after the intensive treatment have been shown to be important prognostic factor. Thus, they have compared this day patient treatment, which is denoted by the name DP, for anorexia nervosa. It can be an alternative to the IP, which is maybe the intensive treatment. Typical DP treatment in Germany, then they have described. So we know no other randomized control trial of DP versus IP. Thus, in this study, we aim to show the non-inferiority of a stepped care model. So they are, because the existing, it was not available, so they have tried that the, it will be a non-inferior margin they have set. And then what they did, they calculated the sample size for one-sided with the significance level of 2.5%. So in this case, they have reduced the significance level, or they have set the same 80%. Non-inferiority margin with the difference of BMI is 0.75. That means with the existing one, whatever was the change in the BMI, they have kept the same change with this new DP also. DP is the daycare treatment, except that 0.75, even if it is within the range of 0.75 less than the existing one, they are going to accept the treatment. And standard deviation they have fixed at 1.45. So if I have to set the value, I'll set the value of standard deviation as 1.45. This margin is 0.75. This is a non-inferior trial with the 80% of power and 2.5% of alpha. So if you see this, this is the assumption. So assume mean difference between BMI between this daycare treatment and the intensive treatment regime, it is 0. Clinically acceptable non-inferiority margin is 0.75 and standard deviation is 1.45. And you can see the level of significance is 2.5 and power of the study is 80%. So let's go to the statulator. We'll use the same continuous data. So difference will be the 0. If you see this is 1.45, the standard deviation, and this non-inferiority margin, it is 0.75. So I will set it as 0.75. And this non-inferiority, because it is a outcome, you are taking it as an increased weight gain. So it is a positive outcome. So I'll set this as a negative. And then I may calculate this. So it is 47. So you can see here the description is also there. But remember, the alpha was 2.5%. So I'll change the alpha. Maybe I'll reduce the alpha to. So the problem with this statulator, it will take either 3 or 2. So I have calculated. So the value is coming as 63 in each arm. So a total of 126. So you can see what is their value. So they have calculated 60. So there was a difference of 3 because that 0.25, it is not coming in the statulator. It takes either 0.2 or 0.3. And then by assuming a dropout rate of 30%, they have increased the this rate to 85%. So this, we have discussed this concept of non-inferiority. What is Manju is asking, like on what basis we select the value for non-inferiority margin. So I have repeated this many times, but again I will say it is set on the basis of the previous literature review, and again with the expert consultation. Again, there is a systematic way for taking this decision, and it is basically the clinical judgment after the discussion with the expert and thorough literature review, how much you will consider as a margin, the clinical significant margin or non-significant margin. So now it is time for you to practice. So this is the title: Comparing Hospital and Telephone Follow-up for Patients Treated for Stage 1 Endometrial Cancer. And that is the NCAT trial, a randomized multi-center non-inferiority trial. Dropout, Varun, in the case of dropout, you are writing that on the what basis dropout was. It is the decision, the author decision. Maybe if the dropout is less than that, you may decrease the sample size. So what is the meaning of dropout? Like, we set a dropout based on your experience and your hospital, maybe the behavior of the people. You anticipate it actually. Actual can be less. So the sample size which the researcher commits, that is the sample size when you will invite those people for a randomized control trial. It is not per se that those people will be there for analysis, because many of them, when there's a loss of the patient, and maybe while you are doing the analysis also, many patients in the follow-up also, they will not come. So generally we keep this range of, for any randomized control trial, we keep it at 20 to 40%. It is up to you whether you want to, if if you are very strict in follow-up and there is some mechanism of home-based follow-up, so then you may reduce this this loss to follow. But generally we keep it as 30%. And if it is less than that, that is very good. If it is you, there are people, I mean, many times you have to commit also, like what is the dropout rate in your case. So in that case, you may write that you have anticipated the actual dropout rate of 30%, but the dropout rate was less in your case. So that can be there. So in this case, now it is your time to do this. I'll just show the objective of this study was to evaluate the effectiveness of nurse-led telephonic follow-up for patients with stage 1 endometrial cancer. And the main outcome measure was the STAIS score. So this STAIS score is the State Trait Anxiety Inventory Scale score, where it measures the psychological morbidity and the patient satisfaction also. So they have said that nurse-led methodology was like a nurse was doing this over telephone rather than the face-to-face. So the sample size was based on the pre-stated margin of non-inferiority, that is 3.5. This is again a continuous outcome because it is measured on a score. So this 3.5 non-inferiority means that higher score means high morbidity. That means high anxiety. Lower score means less anxiety. So this 3.5 means like whatever with the traditional follow-up, it will have only 3.5 score less than, more than that, because it will be worse. So it will be more than 3 point. So that non-inferiority margin is 3.5. So they have taken the standard deviation as 10 from the previous trial, and they have kept the power at 80% and 5% alpha. So now you calculate what was the sample size. Although it is written here, but do it in the statulator. So this is the input value for all of you. So 3.5 is the margin acceptable. This 10 is the standard deviation, and 5% and 80%. So yours is coming 202. So 3.5, 10, 5% and 80. So let's see. This is 0. And attrition, they have not, I think, maybe non-response. Let me check first this. So 3.5. And this expected deviation and non-inferiority margin was 3.5. Sorry, this was 10. I have kept, this was 10. It is 101. So 202. And what was the author? So it was, okay, so he has allowed for, I mean, this 20% attrition. So that's why maybe 100 plus 20% will be 128 approximately. So that's how it will be 121. It is 128. There may be some difference, but approximately it is the same. Maybe with the use of other calculators, like there are various calculators for calculation. So the range might differ from like 5 to 6, but approximately it is coming. So one more question for you. So telephone administered cognitive behavior therapy for treatment of obsessive compulsive disorder, randomized control non-inferiority trial. So this is again cognitive therapy, behavior therapy. It was being given through telephone for the treatment of OCD. So the objective was to compare the effectiveness of cognitive behavior therapy delivered by telephone with same therapy given face-to-face in the treatment of obsessive compulsive disorder. So the primary outcome measure was the Yale-Brown Obsessive Compulsive Checklist. So it is a self-reported checklist, 10-item questionnaire. And they have written that each question scored between 0 to 4 with no symptoms, and 4 is a severe symptom. And the total scale, the total score, they have classified it as very mild, mild, moderate, marked, and severe. So this was the outcome. So it was again a continuous outcome. So using this method, the experimental treatment is not inferior to the control treatment. Again, they have kept it as 2.5% alpha level and below a pre-specified margin of non-inferiority. So this non-inferiority margin, they have kept it as 5 unit. That means even if it is, they are scoring 5 more score than the existing one, this will be considered as non-inferiority. So they have calculated the sample size. So before you see this, let's see the input. So it is 0 difference, because I said that in most of the cases, we take this difference as 0. Why? Because we don't have the existing one. And if you take some value, then the overall sample size will be very large. That's why we have checked with many papers. And usually in all the paper, we have found that they keep this mean difference of the continuous variable to 0. And then, yes, this is 5, this non-inferiority margin, standard deviation is 7.9, and this is 2.5. So total 62. So let me check again. I will also do it. So yes, 5 was what? It is 0. Expected standard deviation was 7.9. And this was 5. So it was 38. But remember, it was this alpha was, I guess, it was 2.5. Let me check. So yes, alpha, they have kept it at 2.5. So that 5% which you people did, that is okay, it is right. But if you just want to counter check, in that case, you can reduce this level of significance to 0.2, because I said that either you can have 2 or 3 and then update. Then you will see, yes, you are right, it is 42. So it will be 84. And if you see their calculation, So they have taken 40 participants in each group. But there was some confusion in this because they have written 40 participants in each group, and then they are saying allowing for attrition for 8 participants. So either they have, if you calculate that 31, which you initially did, 31 or 32. So with this 8, so at the 5% level, if you add this 8, it will be 40. So that's how we thought that they have kept it at, maybe this is not the alpha level, and alpha level is 5% only. There was some confusion in the language, and then the 40 participant by inclusion of the 8 people for the allowance of the attrition rate. So now coming to the proportion. So this we have seen for the continuous measurement. For continuous, that is the mean. Now, if there is a case where your outcome you have to measure in the form of a categorical variable, in that case, the common approach which we have seen in the cohort and case control, we used to have this formula where U is again that desired power. Yes, there's a question. Arifun Hera is asking why they are taking outcome as a continuous when it is a score or a checklist score. So it depends, again, Arifun Hera, because the author, there is a difference between the mean and proportion. If you take proportion, then many times the sample size, in this case, the author has taken it as a continuous because it is up to you. It is up to the researcher, whether you want to take it as a mean or you want to take it as a proportion. It is up to the researcher, right? And both the ways are correct. So in this case, because you can convert this as a categorical also, if the original score is in continuous, if you want to take as a categorical, maybe like the categories which they have defined, maybe the proportion, that can also be done. But in this case, we are just showing the how they have done it, right? They must have done it. So this drafted this webinar, like we took the standard example and we are cross-checking it, how they have arrived to a certain number. So this U is again, it represents the desired power, typically, which is, this is 0.84 at 80% of power. And this V is like represents the desired level of statistical significance, which is 1.96. So that's why in all our formula, you will see we use U and V. And the reference is Kirkwood, because when we read that book, we found that it was easy. That look of the formula was a little bit easy as compared to that alpha and beta, 1 minus alpha by 2, etc. So this, you can see here, this is the formula where P is the P1 plus P2 by 2. And this is the difference in group 1. And this is the difference in proportion in group 2. And this is the average proportion, P1 plus P2 by 2. So the recommended approach is non-inferiority trial, which is the, in this case, it is like equality trial. We have discussed this. So the formula is again U plus V square. And this, we have discussed about this U and V, and that PT is the proportion in the treatment group and 1 minus PT is the proportion in the, the other control group. And then this D is again, we have discussed this D. D is the expected proportion difference due to the intervention. And this delta is the minimal clinical acceptable proportion difference. So this is the one example comparing non-sterile with sterile gloves for minor surgery, a prospective randomized control non-inferiority trial. So what they are using, 2 intervention. The control group is having a sterile gloves, whereas the treatment group, it is the non-sterile glove for minor surgery. So again, if the infection rate is not that much, then you can propose for the non-sterile, because getting the sterile gloves, it involves a lot of other administrative issue. So that's why the objective which they have said, that the effect of gloves on infection rate. So our trial sought to establish whether non-sterile clean box glove were non-inferior to the sterile gloves with regard to surgical site infection after minor skin incision. So they have described that they are not using it for the major surgery, whereas they are using it for the minor surgery. So the sample size they calculated on the basis of the previous study, they showed that the infection rate of 8.6%. So based on the projected infection rate of maybe 8%, they decided that an absolute increase in the incidence of infection of 7% would be clinically significant, and this margin was pre-specified. So to detect this non-inferiority margin of 7%, so they have kept this non-inferiority margin that the infection rate should not be more than 7%. And then that means existing is 8%. So maximum they can tolerate up till 15%. And the power was 80%. It was it was one-sided. And somebody, I think, texted regarding one-sided and two-sided hypothesis. So this one-sided hypothesis is the hypothesis when we say that the new treatment will be better than the existing one, or inferior than the existing one, or non-inferior than the existing one. So you decide the direction of your trial. So in case of a non-inferiority trial, you are always saying one statement, that this will be non-inferior. You can never say that non-sterile glove will prevent infection. Can you say like that? That non-sterile glove can prevent infection as compared to sterile glove, or it can decrease infection rate as compared to, no, that is not possible. There's no biological plausibility for this. But you can at least say that this will have an increased infection rate, but even if it is only increasing by 7%, then you may have, and that is clinically not significant. I mean, that significant non-inferiority margin, you are keeping it at 7%. Because even if there is an increase in 7%, with seeing all those logistic issue, you can still propose that for minor surgical surgery, one person can use the this unsterile or the non-sterile gloves. So how this person has done this? So they have kept this proportion of surgical site infection with sterile glove as 8%, and similar concept here also they will keep the proportion same, 8%. And then the clinical acceptable non-inferiority margin was 7%, level of significance was 5%, power of the study was 80%, and it was a one-sided. So let's do it, this calculation. So I'll also write, so it was 7%, 8%, and 5%. So 7% was the margin. So let's go to the statulator. Here what I'll do, I'll change this interface to proportion. So change this to compare to proportion. If you see this compare to proportion, you can see there is an expected proportion in the reference group. And here you have to change this equality to non-inferiority. So in this case, expected outcome, it was the 8%. So I'll make this 8% will be 0.08. So I'll make this to 0.08. And this will be also 0.08. So, and now what is the non-inferiority margin? So non-inferiority margin in this case was 7%. So it will be 0.07. So it is increasing here. This is 0.07. But if you click this, you will see that this sample size will not come. So it will come to infinity. So there is a problem with the statulator. In the options, you have to, in the adjustment, you have to go and you have to uncheck this continuity correction and then update it. Then this will come 186. So you will see here, what is the sample size? So they have, yes, you can see it is the 186. Can you see? They have also have the same sample size, 186 patients in both the group, in the control group and in the intervention group. So continuity correction, we are not going into that. Basically, we do the continuity correction for the binomial proportion, because here it is the proportion which has got a presence of that wound and absence of that wound. So that is in the form of a binomial proportion. So whenever we apply this proportion, we do the continuity correction because it is not a continuous data. So we have that assumption and we change it. So that's why we do the continuity correction. But in this case, this continuity correction, in case of a non-inferior, it takes this to infinity. That's why you uncheck this and then this works, this tabulator works well. Okay. So then I'll go to the next. So yes, this is the one. Then we'll go to the second example. So second example is 2 weeks versus 4 weeks of antibiotic therapy after surgical drainage for native joint bacterial arthritis. A prospective randomized non-inferiority. So they are saying that existing therapy was 4 weeks and they are proposing a 2 weeks therapy. So now they want to see whether it is non-inferior or not. So in this case, the objective, it was a prospective randomized trial to determine if a post-surgical antibiotic course of 2 weeks together with an early switch to oral targeted systemic antibiotics is non-inferior in inducing remission to currently recommended 4 weeks. So they have again used a non-inferiority design with the alpha level of 5%, power of 80%, expected remission rate of 96% in both study arm. They have calculated that they need 48 patients. So what is the non-inferiority margin in this case? If you calculate the input values, so it is the alpha is 5%, 80%, expected remission rate is 96% in both, and inferiority margin is 10%. So this is 96, 96, 10 and 5. Then I'll go to the statulator. 96% will be 0.96. So I will make this to 0.96. This will also be 0.96 because they both are same. So you can appreciate that in the mean also it was same. Both the mean it was having no difference. It was, and this is 10%. So 10% will be 0.01. So let's keep it to 0.01. And then you can see, sorry, 10% will be 0.1. It will not be 0.1%, will be 0.01. So yes, I often do this mistake. So it will be 0.1. So this will be 0.1. So you can see the required sample size is 48. And if you see this, you can see they have calculated 48 patients in each group. So that's how we can use the statulator. But again, you have to uncheck the continuity correction. So now it's your time to practice. So there's one, this article, gentamicin compared with ceftriaxone for the treatment of gonorrhea, a randomized non-inferiority trial. So the aim of the study was to assess whether a single dose gentamicin therapy is an acceptable alternative to ceftriaxone for the treatment of gonorrhea when both antibiotics are combined with azithromycin. So they are giving in one arm azithromycin plus ceftriaxone and in the other arm azithromycin plus single dose gentamicin. So they are saying that based on 96% clearance for the ceftriaxone regimen, a total sample of 646 participants was required to detect non-inferiority with a lower confidence limit of 5% for the risk difference with 95%, 90% power, and they have kept this alpha error as 2.5%. And this non-loss to follow up also they have kept. So the input which is there for you people, it is again the clearance of gonorrhea with ceftriaxone is 96%. The expected clearance with the gentamicin is also 96%. The clinical acceptable non-inferiority, that means even if it does 91 to 96, 91, 92, 93, anything. And the level of significance is 2.5. Power of the study is 90%. So remember this power and alpha error, many times it gets changed. So you need to put that. So again, if you go, all of you please calculate this. So it is, and this clinical relevant non-inferiority is 5%. So you have done 342. So if you have done this, you can see it was like 342. So it's, again, they have taken this, that power and alpha you can check whether it is 2.5 or not. Another question, discontinuing beta-lactam treatment after 3 days for patients with community-acquired pneumonia in non-critical wards. A double-blind randomized control trial. In this case, the aim of the author was to assess the need for additional 5-day course of treatment with beta-lactam treatment among patients admitted to hospital for community-acquired pneumonia who were clinically stable after 3 days of beta-lactam. So they were saying that whether they should give 3 days or 5 days. So the study was designed with a non-inferiority trial to determine whether 3 days was non-inferior to the 8 days in patients reaching clinical stability after 3 days of treatment. So they have anticipated that 90% of the patient would be cured. So that cure rate they have taken same for both the group by the day 15. And then they have taken the non-inferiority margin to 10% point. And then you calculate this at 80% of, if you see this, so 90% was there with both the expected proportion with the 5 days and the 3 days and the 8 days. Clinically acceptable non-inferiority margin was 10%. That means from 80% to 90%, they are taking it as it is a, it will be a clinically acceptable margin, and level of significance 5 and 80. So it is 201. So what is their value? It is 310. So Deepanvita is also there. Hi Deepa, if you are the same Deepa from Maulana Azad. And so then we can see what is the discrepancy. So Pragya is writing 112. So let's see this. So this is 90%, 90%, 10% and 5%. So what they have done, I'll just show you what they have done. So you people are right, because what they did, just change that input to equality, you will find. So what many people do, they, instead of this non-inferiority, they calculate the sample size either on equality or on equivalence. So if you click this equivalence, I will show you the equivalence also, and expected outcome is 0.96. So 90. So it will be 0.90 here. You can see. And then it is 0.90 here also. And this equivalence margin is 1%, 0.1. So this is 10%. So if you calculate, you will see it is 155. So what they have done, although they have written non-inferiority, but they have taken this as an equivalence trial. So that you will also find. So whatever you have done, that is the correct way of doing the calculation. So now we'll go to the equivalence trial. So this is again, because the sample size was 310, so we did it with the equivalence margin, and it was 310. I guess we can only see, so I'll rush because it's only 5 minutes left. Again, it is just a sensitization, because we are going to have a workshop over the sample size calculation. Then you will learn in a better way, because this is just in this short span of time, we cannot make you people do each and every example. So this is for the equivalence trial. I said that like you did for the superiority and inferiority, in equivalence also, you set a margin which is both the sides, the above and below also. So this is the formula. Again, we did that for the mean. This U and V, now you know what is this U and V. And this sigma 1 and sigma 0 is the standard deviation in the exposed and in the non-exposed. And this mu1 minus mu0 is the mean difference. So but this was for the equality, but for this equivalence trial, mean as an outcome, this is the formula where u plus v square multiplied by sigma square, and in denominator, this is important. That's why the sample size formula is not, calculation is not same, because here this delta, this margin which you define, that is there in the denominator, and that should be there. So this is important to have. And this d difference, we have discussed this, when you make this d 0, usually people make this d 0 for the calculation of sample size, and that's what we are doing for the both mean as well as the proportion. So this is one equivalence trial, no additional benefit of short wave diathermy over exercise program for knee osteoarthritis in peri or post-menopausal women, and equivalence trial. In this case, the objective was, in the present study, they evaluated the benefit of this short wave diathermy supplemented to an exercise program on the reduction of pain and increment of function in the peri-post-menopausal women with knee osteoarthritis. So the response rate of, so now they have taken like reduction in the pain, but over that 10 centimeter visual analog scale, they are deciding that this no symptom versus no problem or intolerable pain. So this sample size calculation, they have kept the sample size alpha at 5%, par as 80%, and then minimal clinically important difference they are keeping at 1 centimeter. That 1 centimeter again on the pain VAS scale, you may define this 1 centimeter as the reduction in the pain, and standard deviation was 1.5. The sample size was calculated 36. So in this case, if we see the input, the mean difference was 0. The clinically acceptable equivalence margin was 1, and then standard deviation was 1.5. So if I go here, what I'll do first, I click this equivalence. This difference I have to take as 0. So what I'll do, this was for the proportion. So I'll go for the mean, 2 independent mean. And if you click the 2 independent mean, I'll go with the expected difference between the mean. So this was 0. Again, this has, I have to click this equivalence, and this one, this was the expected standard deviation was 1.5, and this margin was 1. And then you calculate, because alpha and beta, they are same, so it was 39. So in this case, you see the calculated sample size for them, they have calculated 36. So it is very much similar. Maybe, I don't know why there is some discrepancy, but again, this is very much near to, that is 36 or 39. Yes, Deepa, you are right. Then again, there is one more, we have given one example to you. So azithromycin does not improve disease course in hospitalized infants with respiratory syncytial virus, that is the lower respiratory tract disease. So in this case, the hypothesis was that the use of antibiotics would not lead to a reduced duration of hospitalization in mild to moderately ill patients. Therefore, it was designed an equivalence trial to establish the identical effect of the therapeutic approaches being investigated. So they said that giving the antibiotic is not going to reduce the duration of hospital stay in a mild to moderate, not in the severe case. So the primary endpoint was the duration of hospitalization. So this sample size calculation, what formula what input they have used? So they have taken that this mean duration of hospitalization, they have taken as 192 hours with a standard deviation of 84 hours. This, and the margin they have kept as 39.37, 49. That means even the mean duration was more than 49 hours to this hour or less than this hour, they will keep it as an equivalence. And with the 80% of par and 5% of alpha level. So this was the mean difference was 0. The clinical acceptable equivalence margin, it was 49.3. And then the other standard deviation. So standard deviation was 84. And the par of the study was 5%. So let's go back and we can do the calculation. So it is a mean. So I've clicked the mean. Difference of the two mean was 0. Standard deviation was 84 in this case. So I have 84, and then expected margin of difference, it was 49.3. So it is 50. Yes, all of you are right. So now we'll go back, and for dichotomous outcome, this is the common approach. People use the equality, but we are going to use the recommended one, which is the taking this minimally acceptable difference, which we have discussed. So there is one example, this routine versus clinically indicated replacement of peripheral intravenous catheter, a randomized control trial. So objective was to, we postulated that the patients who had intravenous catheter replaced when clinically indicated. That means when you replace the IV line every 3 days on or on fixed interval, or when clinically indicated, is there any difference between the rate of phlebitis? So they are saying that it will lead to a reduced cost and number of catheter insertion. The number of catheter insertion will also be less if you postulate that it should not be removed on a fixed number of time. So they have used this test of equivalence, and the outcome which they have taken, that is the phlebitis. And the phlebitis in both the group, they have kept it as 4%, and equivalence margin was set as 3%. And they have kept this power as more than 95%, means 99%. So all of you, please do this. So this is the input. Rate of phlebitis with routine replacement of catheter is 4%. Expected rate of phlebitis with clinically indicated replacement is 4%. Clinically acceptable equivalence margin is 3%. Level of significance is 5%. And power of study is 99%. In this case, the alternative hypothesis will be two-sided because it's an equivalence trial. So what is the sample size? All of you please do and type in the chat box. So I think we can, there's one more example, we can skip this. So all of you calculate this, and then we can, I'll show this. Again, you can have all these content over the meritindia.org. That is the website. And you will get a video of this session also, the recorded video session. So Varun is writing 1529. Yes, you are right. It is 1521. And the next webinar is on sample size for diagnostic accuracy test. That means using the sensitivity, specificity, and predictive values. But there is a slight change in the timing. So right now we were holding the seminar from 3 to 4:30. But now we will have these webinar on 2 to 3:30. So the next webinar is on 14th June. And then we are going to start the applied epidemiology made easy series. Because till now we were having a sample size. Now we'll have epidemiology series from 12th July again for the next 1 year on Tuesday itself from 2 to 3:30. So you will get this information over the website also. Do visit the website and see the other content. And thanks to the Clarnet for who's the digital media partner for this webinar. And now over to Clarnet.
Thank you so much, ma'am, for your wonderful session. So with this, we are going to conclude the session here now for today. Thank you everyone for joining.